Yeah, you can do. Yeah, I mean, I did email yesterday, but yeah, maybe people didn't have a chance to read it.
Well, look, I'll begin.
Yeah.
And
yeah,
then
I think start. Yeah.
And then it's all going to be recorded. Many of the slides are very self-explanatory, so you can just come back to them for reference purposes. So it's very straightforward. If anyone has any questions, interrupt me and let me know what they are. It'll probably make more sense to people at the time rather than waiting to the end, I think. I'll try and bash through this. The last time I did this, it was actually 2 webinars, and I've tried to squeeze them into one. So my apologies if it seems a bit rushed, but I've left some of the things out as well. So that's a relief. So anyway, thank you for coming. And this is all just about dermatology, and I haven't limited everything to what we do here at Teladoc only, because I think it would be unfair to just go through that, because many of the things that we see here, you would of course see as well in the NHS or elsewhere, and you might be familiar with the treatment that we can prescribe remotely, but that isn't where the treatment ends. And often you might be asked about treatments, you might need to know about treatments, you might need to know about differential diagnoses. So I'm aiming to look at it more as what you would do as a GP in any environment, and then we have limitations on what we can do in this environment specifically. So dermatology is common for us as well as the NHS. I went through the 129,000 consultations up until now that are on Salesforce, and out of those about 10% were dermatology. So there was only about 10,000 listed as dermatology, but that's probably more to do with the way that the registration is done at the end. People often don't choose more than one thing. So it's common. So I think we should know about it. I'll go through things this evening that we see a lot of, but I won't go through everything. I'll link it to the management that you would need to know about, where you to be working in the NHS, or where you to refer or ask the patient to go back to their own GP in the NHS and see them there. And as I say, if you've got any questions, just please do ask. So we'll cover the commonest things that we see. I've left hair loss out actually, because in the end, the vast majority of what we do is you won't really be able to do anything much with hair loss unless you're actually seeing the patient, doing some investigations and referring. So I have it at the end. If anyone has any questions, let me know, but I've left it out. We see a lot of eczema, and I encountered people who've had various treatments for various durations and various body sites for various degrees of flare, and there's a lot of difference. So I think it's worthwhile just going over some of the basics and getting them right, and being confident that you can treat eczema well and you can follow it up and you know what to expect. So there's a lot of different presentations. It's often ill-defined, poorly demarcated. Not always. There is discoid eczema, which we'll have a look at. It's invariably itchy. That, in fact, is the problem. Because people are scratching, they give themselves eczema. So there's an initial process, but then they beget the process again and again and again through scratching. So you can have vesicles, crust, infection, weeping, bleeding, changing through scratching, pigmentary change. You can have secondary rashes because of the eczema, so you get contact dermatitis, and then you get this secondary generalization eczema. You can get different forms, pompholyx and discoid eczema are probably the two of the commonest ones that cause confusion. And they often have eczema at the end, because often people forget that just because something isn't presenting exactly as one expects doesn't mean it isn't eczema. Always consider it. If someone says, I've got eczema, I've got atopy, I've got a history of this, always keep it at the top of your mind that the patient's skin is eczematous skin. So therefore, they're more liable to have different forms, different presentations of eczema. Here's somebody with typical contact dermatitis. If you see people with contact dermatitis, there's loads of different questions. I won't go through them all, about what could be causing this, it's usually related to occupation or exposure, and it's usually remedied quite easily by giving the proper hand advice. There's a great BAD information leaflet if you want it, just ask. And giving them decent amounts of Dermavate or a strong, potent steroid with some good advice on emollient and cleaning. Don't bother using anything except Dermavate. It just won't penetrate. And if you're getting them to use anything on their hands, be careful about using a circular fashion to put things in the cuticles, because you'll give them a slight paronychia if they rub things into the cuticles in a circular fashion. Very, very common. Contact dermatitis is tremendously common on the hands, common on the face. It can be difficult to find out the culprit, but not that difficult to treat. This is discoid eczema. It's annular. It can be very itchy, usually on the legs in adults who had eczema as a child. You've got to treat it aggressively and with a fairly potent steroid to get rid of it. But I'm just showing it to you because it doesn't look like eczema. It doesn't necessarily look all that like eczema, but this has been scratched and in fact is probably infected. But it's worth recognizing it. This is Pomfilix. You'll see this, you'll have heard of it, you'll have seen it scratched, so the vesicles are no longer present. It's tremendously itchy. Again, they often have eczema. So when you ask them, they say, yeah, I used to get eczema as a child. And lo and behold, in the summer months or some humid environment or stressful environment, they get Pomfilix again. Again, hand eczema, you need to treat it really aggressively with a potent steroid. This is a very typical presentation. She might be sensitive to a fragrance or an aerosol or something, but really it doesn't matter. It's just that you're trying to get rid of the scratch. That's what you're really treating. If you replace the word eczema with the word scratch, then you're onto a winner. Just, I'm going to treat your scratch. And if you can get rid of the scratch, you can get rid of the eczema. Here's somebody who hasn't quite got rid of the scratch, and that is the problem. So when you get people who have recalcitrant eczema, it's usually because they just cannot stop scratching. And if you can break that cycle, you really get on top of the eczema. But that can be easier said than done. This is typical eczema. You see this in children. As people grow up, they get less typical atopic dermatitis distribution and more atypical distributions away from the flexures, on the neck, on the face, on the torso. I always direct parents to the National Eczema Society and patients, and I give them some basic rules again about trying to avoid very common triggers. There's multitude of triggers. Eczema is multifactorial, so it's very, very common to see people who aren't sure what's causing it because there's a whole host of things. So it could be an infection, it could be their stress, it could be their pets, it could be pollen, it could be an aerosol, a fragrance, a cosmetic. It could be a combination of things. So it can be difficult to treat all of that because it's putting their life to one side. It's changing their lifestyle quite a lot. So try and treat it. Don't be afraid of steroids. We'll look at that in a moment. Don't be afraid to give something strong enough to achieve what you're trying to. Antihistamines, they don't work very well. They can put people to sleep, especially children, but they don't really do anything for eczema. It's not a histamine-driven issue. But if you want to sedate someone, that's a different story. If you use the National Eczema Society website, just have a look at it. Spend 10 minutes having a look at it, and you'll see that there's a page on flare management, on steroid use, on emollient use, on how to apply all these things to children, on trigger avoidance. So it can do your work for you. Just get used to using it, and you'll see that it's quite handy to access. There's 3 basic rules, A, B, C. Try and get them to avoid triggers. Do you have a question, Saijo?
Yes, I was just wondering, would antihistamines not help with the itching? Because the main thing is scratching, isn't it? So would that not help reduce?
No, it doesn't really do much. I mean, you know, you can give antihistamines at night to prevent them from scratching in their sleep. But the ultimate cause isn't going to be remedied by antihistamines. And so, I mean, like, we never give them. And people do take them. Sometimes they take them. And I'm not sure whether it's a placebo. I don't know. Amit.
Thanks.
Thanks, Alan. My question was about Pomfilix, really. So I find that quite difficult to treat in NHS and primary care. Often you kind of use steroids, tend to kind of use the dermal hand wash.
Yeah.
It just keeps coming back, and it's kind of, some people are very sensitive to just any sort of soaps or washing just hands. How do you kind of best manage those sort of patients?
Well, I make sure I've removed everything else except what I'm giving them. So avoid any soaps, anything that lathers will contain SLS or sodium lauryl sulfate, and that will trigger or make it more difficult to treat their eczema. I make sure that they've got clean hands. I look for infection. So if I have any suspicion of infection, I'm a bit gung ho. I will treat them with oral antibiotics. I will treat them with topical antifungals. Make sure their nails are short, and then give them a period of occlusion. So I'll ask them to buy some cotton gloves, get some Dermavate, put the Dermavate on at night, put the gloves over, and then get them to come back. If I can't bring them back to me, I'll ask them to send me photos. So the photos come in to, or I'll ask them rather, if they can't come back, to send photographs. It usually works. Some people are being constantly exposed to something and they haven't realized or they haven't told you. I get them to avoid wet work as well, because wet work can be a real problem with hand eczema. And then there are certain things, as I said earlier on, you can't avoid. So if somebody's really stressed out and they're going through something and their eczema is flaring, and this is how it's flaring, there's only so much you can do. You can do everything that you've suggested or I've suggested, and then that's it. You can get control. I do emphasize people, there's no cure. And, I say this is about managing it. It won't go away. And even when your hands or your skin looks clear, it isn't. I often say to them, imagine you had a pair of eczema goggles, and you put the eczema goggles on and you could see your skin. Even when it looks absolutely fine, you can see the eczema bits of your skin. And I tell them to continue to make sure that those parts are treated, even when the skin has gone back to what they think is normal. So I try and make sure that they always have a low maintenance of something. So on their hands, for example, I'd suggest on those areas, even when they seem to be improving, still a little bit of Dermavate over those areas that you think are really going to flare. And I get them to mix up when they put the eczema on. So I say week 1, pick a day begins with T, and put the Dermavate on that day. And on another week, use it at the weekend, and so on and so forth. It prevents tachyphylaxis. It prevents habituation to the steroid. And that's all you can do. And then if that's not working, it's time for them to go and see someone, in secondary care.
Great, thank you.
Which we do. I mean, like we see in hospital, you get people who have dreadful hand eczema, and they've done everything, and it just will not go. They get patch tested sometimes, depending on what the potential culprit is, and sometimes the patch test is negative. We just never figure out what's causing it. So steroids, don't be afraid to use them. They're a tool. Don't be afraid of them. They have their uses. You can safely use them. Be able to titrate them down. You start off hard every day. For example, go and use Dermavate every day on your hands for 2 weeks. And then I want you to use it on every alternative day for 2 weeks, and then come back and see me. That sort of thing. So when you ask somebody to use a steroid for a week, expect nothing. You're not going to get much of anything after a week. It just won't happen. I'd suggest a minimum of 2 weeks before you see any sort of effect, and a minimum of a month before they start to see a real benefit. So don't be afraid to use the strongest one that you can get away with. Hands and feet, Dermavate or Nerasone, if you want something a little in it. It's a slightly different medium, Nerasone, slightly different thickness. And then for the body, Benavate, I prefer Elicon. It's once a day. It's easier to put on, and it causes less sensitization because it contains less preservatives. And then for the face or anywhere above the neck, Umavate or a equivalent. The hydrocortisone is really only for eyes or babies, and only for a limited period of time. You won't get very much effect from hydrocortisone. But don't be afraid to use them for a long enough period to expect a change. And remember, your skin takes 28 days to regenerate. So asking it to show any change or have any effect after a week, the steroid it'll take several days to have an effect at a cellular level anyway. So it's it's just it's not long enough. A week just isn't long enough. So I don't use fingertip units with patients, as sometimes some nurses do and some people do, but I just explain it once that if they squeeze one of the tubes, the amount that comes out, about 5 mils, will be enough to treat that much skin. And I open my hands in front of them and I say that much skin. And I just do that and they go, oh, okay. So they have some idea how much steroid they should be using. So it should be enough to see, but not enough to shine. Just enough, just a very thin film on the skin. And then if I am talking to them about long-term use, which we wouldn't be doing in Teladoc, but you might be doing in the NHS, then I do say to them, look, these are some of the commonest side effects, but I want you to come back and see me well before the chance of those coming back arising is, so that I make sure that they don't continue to use steroids. And I have seen people who've been using strong steroids on their skin for years without any break, and they just had no idea that there were side effects. So it does happen. Every so often at Teladoc, we get people asking, can I prescribe this? You can prescribe it. There's no reason that we can't prescribe it here or anywhere else. These are steroid-sparing agents. They're used instead of steroids, especially on the skin, on the face. They are useful because they're not steroids and they don't have the same side effect profile. They're fairly expensive privately, so sometimes you need to warn patients they're between 35 and 40 pounds for a tube if they're paying for it themselves. So if they're willing to meet that cost, or that's going to be met, that's fine, and then they can start to use them. When they begin to use them, they can sting. So I tend to use them with cross cover from a steroid. So for example, let's say you had eczema on your face or your eyelids, I'd use the hydrocortisone for a week, for example, whilst using Elidel. And then once the week is up, I increase the Elidel and stop the hydrocortisone. So the stinging is prevented and then they're transferred onto this instead. They work very well, but they can be greasy and sticky and some people just don't like them. But don't be afraid to use them. I won't go through too much detail here, just to say there's loads and loads and loads of different emollients. There is no best emollient. They do different things. Whichever one they're going to use is a great one. So if they're saying, what's the best moisturizer? It's the one that you're using. That's the key. It's up to you to talk to them about what they want from the moisturizer, whether they want to just wash with it or whether they want to seal their skin, whether they want to prevent water loss, whether they want to do all of those things. I wouldn't use ointments for soap substitution. They're not miscible. They won't mix with water. So it's very difficult. So you can, but it's very, very tricky to do. These are the basics of why you're using them. You're trying to substitute soaps, seal the skin with something like E45 or Diprobase, soothe the skin, soften it with something like balneum, which contains urea, and there's a higher strength balneum now, 5% balneum, and avoid SLS. So never use aqueous cream because it contains SLS. You can use it to wash with, but even I never use it to wash with, but some people do. And then really what you're trying to do is get them a menu of stuff to use. So you want something that will seal the skin. So you want an occlusive moisturizer. That's most of the creams that you'll see in the market. They will occlude. And then you want something to soften the skin and be a humectant or draw water into the skin. And something like balneum will do that. And then you can mix and match. So you can mix an ointment in, put it on at night, for example, on those particularly difficult areas. And then you can use any one you want to wash with. Dermol is no better than any other moisturizer, although they'd have you believe it is. It's no more better as an antiseptic than using any other emollient. You rub it on, you wash it off. But you can get used to using them in different ways. Give them something that occludes, like Cetraben or Oilatum. Give them something that a humectant that softens the skin, like balneum. Give them a moisturizer, which is an ointment for those thick areas. Give them a steroid. I've just put that in for reference if you want to know how much you should be prescribing, but it should be at least 500 mils a week for an adult. This is a great website for parents to go to learn a bit more about. There's videos and YouTube videos and interviews and loads of stuff on there. So have a look at it. Again, it's a great resource. And here's some other resources as well, which you can all go to. There's loads of YouTube videos on how to do various things with eczema. And the PCDS website is fantastic. They've redesigned it recently as well. So have a look at that. If you ever need anything in terms of resources, there's an explanation of everything on the PCDS website. Any questions about eczema?
Do you apply emollient first and then the steroid on top? Does that help it penetrate better?
Yeah, so there's a lot of controversy about that. Yes, I do. I say to them, if you've got enough time, stick the emollient on first, wait 20 to 30 minutes, and then put the steroid on. But to be honest with you, people are busy. They've got stuff to do. So I just say, look, if you can get it on your skin, you know, that's better than not getting it on your skin. If you can get it on your skin and then wait, I mean, what do you do in the morning? Stick it on and then walk around the house as a bit of a sticky mess for half an hour. It's difficult. So I just say to them, if you can, put on the emollient first. If you can't, don't worry about it. So we see quite a lot of psoriasis patients asking for various different treatments or asking for referral, or they've run out of treatments, or they're not sure what to treat. Sometimes they've been diagnosed with psoriasis. It isn't psoriasis. So I always say to them, who diagnosed it? And often it hasn't actually been diagnosed. They've diagnosed it themselves. But anyway, the management really is directed to the part of the skin that's affected and how active it is. Just like eczema, you're trying to treat it aggressively for a limited period of time. The best treatment for non-genital, non-facial psoriasis remains Dovabets, which is now in a foam called Enstellar, which I use and prefer. It's quite expensive privately, so bear that in mind if you're prescribing it privately. But it's the best treatment. Again, you need to wait several weeks before you really get a benefit from it. And again, making sure they have decent emollients is key. Don't use it on the genitals. That needs vitamin D analogues and less potent steroids, and don't use it on the face either, because it will sting, and again you need less potent steroids and vitamin D analogues for the face. You can use it on the scalp, and there's a form of Dovabet specifically for the scalp. Scalp psoriasis is almost universal with people with psoriasis, but it's treated differently, and it can be difficult to treat because you need to get rid of the scale. So I haven't gone through it here, but if anyone wants any advice on, you know, the algorithm of psoriasis treatment, just let me know, because it's just step-by-step process. One thing that you might not appreciate is psoriasis carries the same Q risk as rheumatoid arthritis. It's not on the Q risk, so you can't plug it in as a risk factor. But if you see someone with psoriasis, it's worthwhile every 5 years for that person to have a Q risk screen. So in the same way as you treat somebody with rheumatoid arthritis, but it's not on QOF, and it's not on, you know, any templates. You'd have to do it yourself. Guttate psoriasis, just a quick word on it. It's very difficult to treat. If you don't treat it, don't worry. It will go away eventually by itself. So you don't need to do anything with it necessarily. The best treatment is phototherapy. So depending on how accessible that is in your area, that can be very, very difficult to get your hands on. You can refer for phototherapy privately, but it's tricky. People can buy phototherapy machines at home, but for guttate psoriasis, it would be probably too widespread for them to use it. So they probably won't be able to do that, and the machines would be fairly expensive. You can give them symptomatic relief, so emollient and steroids targeted at those places where they're really itchy, and then reassure them it will go away. And if you give it enough time, it will go by itself. And you don't need to necessarily do anything with it, but there is a risk that they will later in life develop psoriasis. We see a lot of acne, of course, and I just thought I'd go through the treatments, the basics, because it's fairly straightforward to treat, and we can start treatment that can work, and you can begin treatment that could be later taken up in the NHS or later taken up privately, but you can certainly start it. It's quite common even in people in their 30s and 40s, so don't discount it just because somebody's 40, for example. You can still have acne. Look for the comedones. That's the key. So how do you know it's not rosacea? Because it's comedone. There's comedones. There's blackheads and whiteheads, and very few other things have that, especially on the face. So that's sort of pathognomic. You can use the pill, or women can be put on the pill for it. There's no reason to use Dianet specifically. Any contraceptive that contains estrogen will do the same. But make sure that you haven't missed PCOS. So if you get somebody presenting with acne, just have a think, could it be PCOS? I always ask about hair, weight, and menstrual cycle, just to make sure. And then if somebody's been through the treatment and they're thinking about getting referred for Roaccutane, we get quite a lot of people coming in saying, can you refer me to dermatology for my acne? There's only one reason that dermatology would see somebody for acne, really, and that's because they would start them on Roaccutane. So talk to them about it. It's fairly successful. Give them a leaflet, or give them the URL for the leaflet, and warn them about contraception. So tell them you're going to have to be on contraception for at least a month before and at least 5 weeks after it. You need 2 methods of contraception. They'll need to sign a waiver making it clear they are on contraception. They'll need to have lipids and LFTs checked before they start, just so they're aware of what they're getting into. But it does work. It's fantastic medication for its purpose. So you can just set them up a little bit and give them some useful information. I always start everyone on Epiduo and Duac, and the reason is Epiduo contains a retinoid which has the best evidence of anything topical, and benzoyl peroxidase, which is an anti-inflammatory, which also has good evidence in acne. Duac contains clindamycin as well, so you've got all 3 things that you need in those 2 products, and you can use one at the beginning of the day and one at the beginning of the night. I tell them to I show them that there's a video, great YouTube video on how to do this. I can send any of you the URL, and it shows them what to do. And they basically wash their face, put one on in the morning, go about their business, come home, wash their face, put the other one on at night. They don't put it on their eyelids, they don't put it on their lips, but target everywhere else. So don't just target the spots, put it all over the face. Tell them they'll see no change for about 6 weeks, and it will dry their skin. Suggest something like Cetaphil moisturizer to prevent the dryness, and to use them as a cleanser. And then take some photographs, take a baseline photograph and ask them to take a photograph at 6 weeks and see, is there a difference? And if they're unhappy with that, they can go on to antibiotics, various different antibiotics, tetracyclines primarily. And then if that's not working and they've been through tetracyclines and macrolides and even trimethoprim, then it's time for Roaccutane. Or if they're scarring at all, they should be referred ASAP for Roaccutane. We see quite a lot of rosacea. It's very, very common, of course. So I'll just have a quick word about it. Don't need to read all this. It's just for reference. This is thought to be a dermadex mite interacting with UV and causing an inflammatory process which causes papules and redness. And then you get these changes, these telangiectasia, which are irreversible. If you're trying to treat the papules, give them cilantro. You can use other medications. You can use various different oral medications or Rosex gel, but ultimately cilantro has good evidence. It's easy to put on. You take a pea-sized amount and put it on the affected areas. It usually works after several weeks. It's easy to tolerate, and it doesn't have many side effects. It's expensive privately. It's about 42, 43 quid. So again, they may prefer to get it from the NHS. If they're trying to target the blood vessels, be honest with them. There's no medication that will work very well. There's a list of the medications they can try, but none of them work all that well and they have side effects. I recommend going and getting laser if they can afford it. It's not that expensive. You can have a test area done, so they can choose an area, they can do that area. It's a limited amount of money. You can see if you like the effect, and if you do, go back and have more. Ocular rosacea, we don't see very much of. If you're concerned they have ocular rosacea, I'd suggest leaving it to somebody more specialist referring them or giving them doxycycline to see if that works as a trial. But I wouldn't do that in Teladoc. This is some advice I give everyone just about avoidance of triggers. You can have a look at this, and there's some great websites on how to treat your rosacea yourself and how to use the types of makeup that will help to hide it. We see quite a lot of perioral dermatitis or periorificial dermatitis, and this is where there is a papular red eruption, usually around the mouth, which spares the lips or around the eyes as well. Not that uncommon. It's usually that people have gotten themselves into a cycle of using something containing a steroid for some sort of rash, or it was meant for another rash and then they stuck it on their face. And then they stop using the steroid, they get a flare, so they start using the steroid again. And they get into this cycle. And you've got to get them out of the cycle by removing everything except a bland emollient to wash with and asking them to come back in a month. If it continues, you can start to treat it as an infection, looking for other causes. So you can treat it with anti-yeast or anti-biotic infection medication. But ultimately, once you stop the steroids, you can expect it to eventually recede, but it takes some weeks. We see a lot of urticaria with various different antihistamines given. There's no real clinical benefit over one over the other. So cetirizine is faster acting than loratadine, which is longer lasting than cetirizine, and fexofenadine is somewhere in between. Whichever one people prefer, really, is the right one. You can pretty much treat it. If you look at CKS, you can actually quadruple the dose of antihistamines according to NICE within general practice if they are not responding. A lot of people aren't happy to do that. They think there's going to be side effects. I think if, at Teladoc, I wouldn't do that because people will just keep coming back for more antihistamines and it wouldn't be safe to do so. But if you're in the NHS and somebody has urticaria, it may be necessary to do that, especially if you've referred them and you're waiting, and they're waiting rather for that appointment. But just to show you what is happening, you get this sort of quite well demarcated urticated rash. So this is what distinguishes it. If you close your eyes and you feel your skin, there is a difference. It's raised. I say to them, does it look a bit like a map of countries? And they say, yes, it does. And it often does look a bit like that. So it's not there for very long. Typically, acute urticaria will last less than 24 hours. A chronic urticaria is a different story, but typically it will last 24 hours or less. It's often not as well demarcated as this, but it is well demarcated. You can see it all over the body, but it's most common around the upper torso. You don't have to read any of this, but it's just for reference. The point of all of this is don't really bother looking for a culprit. You can ask about particular triggers. For example, is it triggered by heat, water, exercise, cold, medications? Are you on non-steroidals? Are you on any other medication? And rarely people have a history, eventually rather, have a diagnosis of a hematological malignancy. But you can't know that. You can just ask them about systemically how they are. You may never find the cause, though. That's the point. You have to stress to them that even with testing, they may never find the cause. They can go for IgE testing and they could be positive and for certain things, but that's not driving their urticaria. And they could be negative for things. It doesn't help to determine what's causing the urticaria, unfortunately. The key really is to treat, to prevent it from interfering with their work, their school, their career, whatever it happens to be, because it's very itchy and very annoying. So don't be afraid to treat it. And there's a list here of all of the potential treatments. So these are all of the antihistamines. As I said earlier on, cetirizine, fexofenadine, loratadine, they're absolutely fine and they work very well, but there's no particular advantage of one over the other. We see quite a lot of sebderm. This is a little cartoon of a typical presentation. It's not always that clear, but look for red flaky areas around the central part of the face, up onto the glabella or down onto the chest. this is the treatment. So this is it. You can add in various other things, but this is pretty much it. And this is a treatment protocol that pretty much works. If it's not working, I would reconsider the diagnosis. Could it be SIBO psoriasis, or am I missing something? Is there another infection present? So therefore, I would suggest do some blood tests. Are they immunosuppressed? And if not, why isn't this treatment working? If you're thinking about systemic treatment with oral medication, something's not quite right. And so I'd start thinking, well, is the diagnosis wrong? Or are they immunosuppressed? We see a lot of folliculitis, and it's very common. It's usually associated with something that somebody's doing to their skin, like shaving, and then they get a kind of a staph overgrowth on the beard or the area that they're shaving, or they get a traumatic effect from what they're doing. So folliculitis barbae is where they're getting the staph carriage in their beard, and the pseudo folliculitis is where they're actually doing this to themselves. They're actually shaving the beard area, or the area that's been shaved is being traumatized. So you need to get them to stop shaving. There's also folliculitis from wet areas, so Pseudomonas folliculitis, which is not that common, but I see it diagnosed quite often. And then there's also yeast folliculitis. So you can quite easily treat these things using various anti-infective treatments. And if it's not working, you get them to come back. So you can always say, here's the treatment. If it doesn't work, you need to come back and see me. You need to see a GP in a month, for example. If it's somebody who's shaving, get them to stop shaving. Some men are very stubborn, despite telling them to stop shaving and that you need to stop shaving or it won't stop. They won't stop shaving. But you need to stress to them that it is shaving that's causing it. So ask them to stop, buy an electric razor, give them a mild steroid, something like Trimavate, to rub on in a mild fashion in the neck or wherever is the worst area affected after they've shaved. For the body, choose the treatment that you think is appropriate. So it might be Nizoral if you think it's Malassezia, it might be Hydrex if you think it's a bacterium, or you might need to give doxycycline. If it's Pseudomonas, you might need to give ciprofloxacin. And Pseudomonas can also affect the ear as well. So you might see it being causing a swimmer's ear, so you might need to treat it locally. So this is a little bit about fungal infections. I just wanted to show you how widespread it can be, but also how that picture on the left upper area is ringworm, and that picture is granuloma annulare. And there's loads of different annular conditions which can look like ringworm. So if you see somebody being treated for ringworm repeatedly, it's not ringworm. So that's okay. You don't have to diagnose it, but it would be wise to refer, because they might need a biopsy. It might be something else. It could even be lymphoma. So you need to start thinking, why is it not responding to typical treatments? And typical treatment is Lamisil. So if you can give Lamisil, it does work. Make sure that you apply it to the area around the lesion and not just the lesion. You can add Nizoral if there's a more widespread area affected, and get them to stop doing things that might be spreading the infection. If it's not going, start thinking again, is the diagnosis right? Or do I need some help? Do I need to reconsider, are they immunosuppressed? I've put this up only to stress the fact that if you see or you hear of thrush in a prepubescent girl, it isn't thrush. So they shouldn't be having itching at that age. And if they are, they need to be examined. So don't assume it's thrush and treat it. Same in the elderly, actually. A lot of older, I shouldn't say elderly, but older women are treated for recurrent UTIs or thrush because they're getting itch, when in fact there's no evidence of either. They need to be examined and make sure they don't have lichen sclerosis, basically. So never assume without an exam. We see loads of impetigo. Just simple points. Don't forget the school occlusion. So just tell them about it. Make sure that if it's bullous, that you're treating it with a oral antibiotic. Warn them about Fluclox tasting dreadful, but do give it. Clarithromycin or erythromycin are alternatives, but they have problems with prescription. And then if you need to give them a very tight safety net. If it's not really clearly responding within 2 days, they need to be seen again, even if you're in the NHS. Impetigo used to kill people. So, we need to just remember it can be really serious and it can spread like lightning. If they have eczema, it can make it even more difficult to treat. So go in heavy, treat with an antibiotic, an oral antibiotic. Make sure that they're seen soon after treatment begins. This is pityriasis. You see a load of it, just to emphasize, you don't always see the Herald patch, but it's harmless. If you see it, these sort of rose petal, annular, teardrop-like shaped pink lesions, usually on the torso, you can treat symptomatically, but you can just reassure and ask them to come back if it gets worse. But also, ultimately, it's just a bit itchy, a bit of an annoyance, doesn't do anything else. I've put this up just for reference. It's a reference table for the type of antibiotic that you would give for particular infections. We see a lot of coamoxiclav being given for infections above the head or in the head. It's not necessary to do that just because it's on the head. Coamoxiclav will treat anaerobes as well as aerobes. So if you're thinking about it being a skin infection on the face or on the head, but it's unlikely to be anaerobic, give flucloxacillin. It has a higher penetrance for skin. It's better for skin than coamoxiclav. Amoxicillin is a poor substitute. It doesn't penetrate the skin well at all. And lastly, scabies. So scabies is very difficult to diagnose. People get it wrong all the time. I've seen consultants go, no, it's not scabies, and it's scabies, because it can be amazingly itchy and the person can have eczema and it's thought to be the eczema. It can have been treated. If it's treated, it should have gone away, but not necessarily. The treatments that we have don't kill the eggs very well, but the treatments that do, we can't give. So if you think it could be scabies, it could be scabies. And the purpose of this is just to remind you of that. If you think it could be scabies, it could be scabies. There's a wide differentiation. It could be folliculitis or a nodular prurigo or dermatitis herpetiformis. There's other things as well, but just remember it and always think, well, it still actually could be scabies. So if you think it might be scabies, don't be afraid to treat it again. And that's it. That's a whirlwind tour. I hope it's helpful. Any questions? Hi, Simon.
Hi, that was really, really great. Thank you, Alan. I'm still a bit confused about how much we can do at Teladoc.
Yeah.
So say like yesterday, I saw a patient with clearly peri-orificial dermatitis on her face, and I just thought we couldn't start long-term treatment because then that kind of then they go back to their GP and they ask for something which we've already started, which might upset the GP. So I mean. What can we do? Because often they can't get an appointment with the GP for a while. So I gave this lady metronidazole gel, and I said, you may not notice an improvement for 6 weeks, and we won't be able to prescribe it again. You will need to follow up with your GP. But I mean, from what you've told me, it sounds like we might be able to do more. I mean, can we start someone on oral antibiotics for acne or for peri?
We can. Yeah,
we can.
Yeah, we can. We can't give full course because obviously you can give a month and you can start the course. You can give them the same advice one would give with an antibiotic about warnings of side effects and photosensitivity and gastric upset and what have you. But you can still start them because it is a standard treatment. But you can say to them, look, we cannot continue. This needs to be monitored. You do need to go and see somebody in the flesh and have this monitored. But the nature of general practice at the moment is such that people are struggling to get appointments. So if we can start something that doesn't require monitoring through a test or a physical appointment, then we can begin it. We can begin something like doxycycline or limecycline. But unfortunately, they do then, so they have a little bit of a cushion. They can start the treatment, they can expect an effect, and they've got enough time to then organise an appointment. And unlike other conditions, acne is fairly benign in terms of insulting other GPs. I think we can all agree what acne is, and we can all say, well, we know what the treatments are for acne. So it's an unusual, it's an exception, I suppose, in that regard.
Yeah, and I guess you can get them to have the photos before they started treatment, so that when they go and see their GP, they can say, well, look, this has clearly worked. I'd like to continue it for another 2 months.
Yeah, absolutely. I mean, the guidance from consultants is that people shouldn't just be left on antibiotics, which they are often, and that's the danger, not from us, but from the NHS, that people are just repeatedly given another 6 months of limecycline or something. So you need to, I always say to them, take the photographs. You should expect to get the maximum benefit from this in 6 months, and that's it. That's that. And so we can start that process, give them the proper advice. They have the photographs, and as you say, they then have evidence as to whether it's working.
Great, thank you.
Alan, I had a question actually. You mentioned about lichen sclerosis, weren't you, earlier? Particularly,
Yes.
I suppose men get it a lot, and they get sort of a lot. They get sort of associated phimosis with it, and
Yes.
often they don't want to be referred for like circumcision, because obviously I think that does cure it and address the issue. And often I see dermatologists try and treat it with steroid, which often doesn't work. I mean, what's your experience with that? What's your general
Yeah, I've
advice?
seen a lot of this and treated a lot of it, and unfortunately, by the time they get to me, it's usually too late. They could have been given Dermavate months and months ago, but they didn't get it, and so they've got a phimosis, and it's irreversible, and so they've got no choice, and I just refer them to urology. So I wouldn't be afraid to treat it. I mean, I say that because I feel confident in recognizing it, but if you don't feel confident in recognizing it, then you're not going to be confident to treat it. So if in doubt, try and get hold of somebody who has a bit more experience with it and say, do you think that this is lichen sclerosis? And the thing to do is to try and prevent it from getting in that state where phimosis is irreversible. So there's so much fissuring that that's it. It's done for. So there's not much that you can do. I mean, in general practice, I'm just very frank with them, and I say, unless you treat it, this is what's going to happen. So you need to treat it promptly, and you need to treat it aggressively. And I give them the same advice that I give women with lichen sclerosis in terms of the follow-up. So I have a patient information leaflet about what they should expect, where they should treat, how they should manage it, and when to come back and see me. And it's absolutely key that they come back and see you, of course, because if they don't, which men are hesitant to do, then inevitably, if they did need a circumcision, they won't get it, and things will get worse. And if there's any transformation or any problem with the mucosa, and there's any malignancy or anything like that, it won't be picked up. So it's absolutely key to get them to come back. But yeah, I agree. It's tricky with men. You know, they don't want to talk about it. They don't want to show you, and they don't want to have the treatment. And often, I mean, I don't know how many times I see it, and it's just too far gone, and they just end up with the circumcision. Unfortunately.
Yeah, thanks, Alan. Yeah, I think again, I don't know what a reasonable treatment would be in primary care, but what, 2-week course of Dermavate, or what's
No,
sort of
well,
regime?
it's a 3-month course in total. So you use it. You put Dermavate on for a month every day. So you target it. I show them how to do it, and I basically put it on my finger, and I say, look, this is what you put it on. I show them the frenulum and the coronal sulcus, and I say, this is where you should be targeting it, etc., etc., etc. It's often asymptomatic in men, so you can't say put it on the itchy bits like you can in women. So I show them what to do, and then I say, do it that for a month, then do it every second day for a month, and then I bring them back after about 8 weeks. With women, I bring them back after 3 months. So it's a month of Dermavate, a month of alternate day Dermavate, a month of twice weekly Dermavate, and then you bring them back. But with men, I bring them back a bit earlier. to see, because at that stage, at 8 weeks, you'd expect it's either going to work or it's not
Yeah.
going to work. That's that.
Yeah. Makes sense.
They're done. But yeah, Dermavate. So, you know, a week of Dermavate, not going to do anything. You need to turn off that inflammatory process, prevent any more inflammatory tissue, and that takes weeks. I also give them this advice about self-care in terms of urine. So the way that they urinate, making sure that they're dry afterwards, that they're not dribbling. Also, if you're going to use Dermavate, ask them if they've ever had genital herpes. It can reactivate the genital herpes, so be careful. So if you can still give it, of course, but you have to warn them if they see any new lesions, any new blisters, or any new painful areas, that they might have herpes coming back.
Great, thank you. I think Sergio had a question.
Yeah.
Alan, you said we can give lymecycline, or we can start them on lymecycline or equivalent for acne at Teladoc. They're invariably going to call us back in a month to say, can I have more? So can we then do the second month?
No, I mean, we do get, each week I see a number of different prescriptions for lymecycline and doxycycline for a month.
Okay.
And that's it. So I mean, I don't go through all of those notes and go, well, I don't know what that GP is saying to that patient, but it's only for a month, and they don't come back. I mean, they've been advised. I'm allowed to give it to you for a month. I won't be allowed to continue it. We can't do that. You need to go and see a GP who can give you a longer supply. I mean, you can, of course, you can't prevent them from calling back and asking for it. But no, if you're clear with them and say, look, we're not allowed to do that.
So yeah, so when we're doing the initial prescriptions, I think we need to set the patient expectations, isn't it? So that they know, and document it.
And document, exactly, in the same respect as we do when they're asking for a repeat medication and they come back for a 4th month, and we've already documented you've had 3 months and we did ask you to arrange it elsewhere. I'm sorry, but you need to go and do that.
Yeah.
So I'll put the webinar onto the resources channel. And if you need anything, or if there's anything that you'd like me to cover or explain otherwise, just ask me. I mean, obviously this is not exhaustive. It's just what we, see most of, but there's a host of other things, of course. So if you need any help or any advice, just let me know.
Thanks, Alan. That was really useful. Really useful. Thanks a lot.
All right. Okay.
Did anyone have any questions about anything else at all, or general Q&A at all? No, looks like everyone's happy. Okay. Enjoying the new way of working.
Good.
It's great. It's brilliant.
Well, thank you, everyone.
Yeah.
And as I say, if you've got any questions, just let me know. Just let me know on Teams or email me, and I'll see you all soon.